I'm a native Houstonian. I am una chinita, pero hablo más español de chino. And so, so talk about stereotypes. You know, I run into people all the time. Like I said, I was born in Houston. My mother is Chinese, but she was born in Augusta, Georgia. So I have very southern roots. And then my father is from Guangzhou, China. So he, is from southern China. But anyway, then I was the first Houstonian in my family to be born in Houston. My older brother was born in China. My older sister was born in San Antonio. But because of discrimination, they would not sell a house to my parents. And so we moved to Houston, which actually had some friendlier people at that time. And that's why we came to where we are. So I want you to know that every racial ethnic group has experienced discrimination. And it's not, I don't want to rail against the machine, because my parents came to America because it was a land of opportunity. So there are some things that we have to deal with. And, there's some very good things about America. So I don't want to, like I say, be someone who's real negative, but rather let's do the best we can. I think one of the things we need to realize about America is that we are a nation of immigrants. And we can't compare ourselves to some countries like Norway or Sweden where everybody's the same, We are a land where everybody came here for opportunities or for freedom. And so, anyway, I get on my soapbox about that. And so I think we need to learn how to get along with one another, and there are positive ways to do that. So anyway, why discuss mistrust? I found a saying that said, trust is a linchpin in the provision of high-quality care, especially when healthy individuals are being asked to undergo screening or sick patients to adhere to complex treatment recommendations. So you can see it's key to us going in for health care. And like many of you have said previously, because of being immigrants, because of being people from various cultures, we have different perspectives on health. As I mentioned to you, I have what they call an ABC mother, American-born Chinese mother, but I have an overseas-born father. And in spite of being, very limited in my Chinese proficiency, Mom and Dad taught us a lot about Chinese culture. We eat this, because it's good for you. It tastes bad, but, do that kind of stuff. So, those sorts of stories, So when you try to, when the Western medicine tries to tell us this is good for you, many people back away, right? So there's some perceived racism in healthcare. We talked about that. There's been a lot of talk about medical errors recently. So can you imagine how that compounds medical mistrust? There's been some unethical treatment that's been given to people. And recently you heard about the big case in Oklahoma where there was a dentist to expose 7,000 people, risk of exposures. There's limited health literacy, dissatisfaction with healthcare and healthcare providers. If you've had one bad experience, you're unlikely to go again. And like I say, different perspectives on health. Many of my father used to always say, so he passed away in 2005, but he said, if you eat good and you sleep good, you don't need to see the doctor. So, the preventive mind care setting is I only go to see the doctor when I'm sick. So when we tell people, oh, you need to go for cancer screening, you need to go for checkups, they're going to find something wrong with me because then they can get money from me. Mistrust, right? Anyway, the consequences, though, of mistrust are very bad, that there is underutilization of health care. And someone just said this recently. Even with people becoming insured, many people don't utilize that health care services. There's lack of preventive screenings, late diagnosis as a result. So, unfortunately, when we see the statistics on health disparities, particularly cancer, which is a lot what I work in, it's late-stage cancers because people don't go in for screenings. There's dissatisfaction. Again, dissatisfaction can be a reason for the mistrust and a consequence of the mistrust. There's a lot of misinformation. We talked about that. I work like Marissa was saying, a lot in the Asian community. And one of the things that I'm very proud about is that we started the first Asian American Komen project, breast cancer screening project in the Houston area. And the myths that we heard, I remember my colleague Lynn Nguyen said that many people in the Vietnamese community were saying, I didn't have breast cancer until I got on that mobile mammography van. So that's the concept that they had, is that they were fine until they found out there was a problem, There's a lack of health data on underserved minority populations. Again, Kim mentioned earlier that Dr. Jones and I had the privilege of doing probably one of the first ever Asian American health surveys in Texas. In fact, Our first speaker talked about the YRBSS. We did a BRFSS, the Behavioral Risk Factor Surveillance System among Chinese and Vietnamese, and now we're getting ready to do one in the Filipino and the Asian Indian community. So anyway, just to talk a little bit about the evolution of medical treatment. You know, you might have seen this slide before. Way back in the Dark Ages, people said, here, eat this root. And then later on, that root is heathen, say this prayer. And then that prayer is superstition. Here, drink this potion. That potion is snake oil. Here, swallow this pill. And now we come around. That pill is ineffective, has side effects. Here, take this antibiotic. Now we come to that antibiotic is artificial. Here, eat this root. So we kind of come full circle. And someone mentioned that earlier, that National Center for Complementary and Alternative Medicine is now looking at the efficacy of many of our alternative therapies, which have been around for ages. Now, me and my siblings sit around and talk about all the herbal medicines that Chinese people consume. And we said, I wonder how many people had to die in the testing, you know, because back in the day, it's just like, well, try this, you know. But anyway, that kind of gets at where I'm going, is that in the history of human medical research, we had to try things on people. And the first documented things we see is in the first century with a man named Celsus, who experimented on condemned criminals. Now, of course, criminals were considered people of very low merit, and so they said, well, let's test things on them. So that was probably one of the first times that we have recorded experiments on humans. And then in the 1700s, Louis Pasteur with his vaccination trials, 1900s, Walter Reed with the development of the yellow fever inoculations. But probably one of the sentinel events was after World War II, when 23 Nazi doctors and scientists were tried for the murder of concentration camp inmates used as research subjects. And this led to what they call the Nuremberg Code, that there's a guidance for human research, that we need to have informed consent, that research should be based on prior animal work. Now, something that I've asked a lot of people is, are there Chinese rats, though? You know, so how do I know this is going to work on Chinese people if, you know, if you don't have Chinese rats? Anyway, risk should be justified by the benefits. Did you get my point, though? Are there black rats and Asian rats and Hispanic rats? So anyway, there's that only qualified scientists should conduct research. And so there has to be some certification, some credentialing in order to do human research. We want to minimize the physical and mental suffering, and the research should not result in death or disability. There was a declaration of Helsinki subsequently in 1964, the World Medical Association, because the Nuremberg Code was there, but it didn't have much teeth to it. And so, again, they revisited it in the Declaration of Helsinki, and they made it stronger and focused on medical research with therapeutic intent. And, in fact, you know, everybody in academia, you publish or perish. So journal editors started saying, unless you have your research comply with the declaration, then it couldn't be published. And then we came into institutional review boards, the big IRBs that all of us have to deal with. Now, so many people have heard of the Tuskegee syphilis study. And it's probably known as the landmark breach of confidence, breach of ethics in human research. It's probably not the first, but it was probably the most documented. And so these were some of the facts. It was done in Macon County, Alabama, between 1932 and 1972. And the purpose was to document the natural history of syphilis among African American men. And at the start of the study, there was no known treatment for syphilis. Well, some of the problems, of course, is that there was inadequate informed consent. The people were not really told fully about what the study entailed or what would be expected of them. They were given a necessary test. In reading about this, I found out many men were given spinal taps unnecessarily. And even after penicillin was found to be effective against syphilis, men were still not offered treatment. It resulted in 28 deaths, 100 disabled, and 19 cases of congenital syphilis. So that's probably one of the big things that came about. But some other things that you may not know about it, there's also been medical abuse of Hispanic and other women. And someone touched upon this earlier about the eugenics movement, that more than a third of women in Puerto Rico were sterilized in an attempt to reduce the population, because it was thought by the government that there is such few resources. How are we going to take care of all these people? Well, let's thin the herd. Virtually, that's what they were doing by sterilizing people. Birth control pills were tested on Puerto Rican women in 1950s without their consent. Mexican-American women in San Antonio thought they were receiving contraceptives but were receiving a placebo, and many of them became pregnant as a result. I looked actually for instances regarding Asian Americans, and I have to say I couldn't find a lot in the literature. Not to say that this didn't happen, but the one that I did find was against Cambodian prostitutes. Now, unfortunately, there are many prostitutes in Cambodia, but what happened there was the NIH actually sponsored research there, and they recruited 960 prostitutes to receive counseling about safe sex practices, monthly testing, condoms, and $3 a day for transportation. And the medication they were looking at was called Viriad. If it proved effective as a preventative, participants would receive a free supply of it for 2 years. But anybody that was contracting HIV would have to rely on just Cambodia's low standards of health care. So it's kind of like, no thank you. And so a lot of the Cambodian prostitutes actually band it together and say, we aren't going to do this, and we're smart enough to kind of protest against this. There's been much medical abuse of Native Americans. I have the privilege of having a friend, Cheryl Downing, that Dr. Jones knows, who's a full-blooded Alabama Coushatta Indian who really taught me a lot about the Native Americans. But unfortunately, as has been mentioned several times, the Indian Health Services is usually underfunded. So even though it's said that that is the, default service for Native Americans, it's really very inadequate. And Native Americans have accused the Indian Health Service of sterilizing at least 25% of Native American women during the 1970s. Most recently, you heard about the University of Arizona and the Havasupai tribe. They filed suit in 2004 against the University of Arizona, claiming that more than 200 blood samples were gathered under pretense of studying diabetes, and those samples were misused. So as you can see, this is not a one-time thing. In Houston, this is our friend Anna Edwards, who's actually part of the San Juan Pueblo Indian tribe. And they reported about how she's having such difficulty because of the lack of services, lack of funding for Indian health services. And I know my friends back at the Native American Health Coalition in Houston are trying to start a urban health services, but as mentioned earlier, the funding is just not going to be there. I have the privilege of being, as Marissa said, co-founder of a group called the Asian American Health Coalition, and we got our federally qualified health center designation last year. So we are really considering saying, share our facility, Native Americans, until you can get your own. So hopefully we can start working together like that. Because I do consider the Native Americans my cousins. I think there's a lot of similarities. Yes, our eyes. Okay. The Willowbrook hepatitis study was a study that took care of mentally retarded individuals in New York. They wanted to look at the natural history of infectious hepatitis and the effects of gamma globulin on preventing or ameliorating the disease. And so virtually what they did is they took children that were institutionalized and infected them with hepatitis to see what would happen. And they even prevented parents who wanted to put their child in this facility from admitting their children unless they agreed to participate in the study. There was a study called the Jewish Chronic Disease Hospital Study in 1963. And this is pretty recent history. Live cancer cells injected into senile patients without their knowledge as a part of the study of immunity to cancer. Investigators believed the cells would be rejected, so they did not inform the patients or seek their consent because they did not want to frighten them. And then this was a study done against the GLBT community, the tea room trade study. And I have to say, when Venus asked me to do this presentation, I had to do some homework because I really wasn't that aware of a lot of the medical atrocities that have been done even in the U.S. We think of Nazi atrocities and so forth, but these were done here in the U.S. This was a graduate student at Washington University in St. Louis who published something called the Tea Room Trade, and it was a study of homosexual accounts in men's rooms. What he did is he pretended to be gay, and he said, I'll be on the lookout if you want to go into the men's room. But he recorded the license plate numbers of participants to obtain their names and addresses. He waited a year, disguised his appearance, and then he went back and interviewed 50 of those tea room regulars at their home. So this, of course, made a very embarrassing situation for these men, and he even published his dissertation based on that data. So this was a very, very much abuse of a population. So the ethical problems in research, lack of informed consent, coercion or undue pressure on volunteers or on parents to volunteer their children. There's a use or exploitation of a vulnerable population, withholding information or treatment, putting subjects at risk. Risks to the subjects outweigh the benefits, many times deception and violation of human rights. So what should be done about medical mistrust? Well, probably one of the, again, sentinel things that was a follow-up from the Tuskegee study is President Clinton did make a formal apology to those few remaining people who were in the syphilis study. And this is a photo from that occasion. But that's, just one thing. What can you do when such harm has been done? And since then, of course, too, the Belmont report, the Congress formed the National Commission for the Protection of Human Subjects, which has 3 principles. Respect for persons. You need to treat individuals as autonomous human beings and not as a means to an end. Beneficence. You need to minimize the risk and harm and maximize the benefits. And justice, as much as possible. Equal access to participation in trials and avoid exploitation of vulnerable groups. So your role in reducing mistrust is you always want to obtain informed consent if you are going to be having people participate in some kind of study. Make sure it is understood by participants. Ask yourself, can this study really benefit the person? Is the selection process fair? You want to recognize power relationships. That's a big deal. I think for many of us, when we work with underprivileged populations, they say, you're the doctor, you should know what's good for me. I know many Asian people, Kim said this earlier, they go like that. And they don't necessarily mean yes, but they're just trying to show respect for you. And you need to realize that you, as a professional, particularly health professionals, are seen had to have more power than them, and they feel very powerless sometimes. But you need to have this, how do you say it, leveling of the playing field. Acknowledge conflicts of interest. You want to avoid coercion. Now, a lot of people, $25 incentive is a lot of money. And so we need to realize that for some people, they may participate in a study just to get the incentive. We need to look at those things. We want to incentivize, but we don't want to coerce people. And is the participant privacy protected? This is just some examples. Kim and Dr. Jones referred to the Asana study we did. And it's not real clear, but, when we recruited people to this study, we made sure all of our flyers were in Chinese and Vietnamese. We went out to the community. We went on Asian media to let people know about it. We set up a hotline so people had questions about it. Not that this is an ideal study, but just shows you some of the links that you need to go to if you're going to recruit people to clinical trials or to certain things that you want them to do. And institutional review boards. More and more they are asking community members to be parts of IRBs. And I would say if you get the opportunity to do so, you should. IRBs approve, disapprove, or modify research. They conduct continuing reviews. They oversee them. They suspend them if they're not going well or someone's getting hurt. And they observe the consent process. IRBs have to have at least 5 members. They have to be of both genders, varied professions, at least one non-scientific individual, at least one individual unaffiliated with the institution. It should be diverse racially, culturally, sensitive to community attitudes, and the knowledge of institutional regulations. So I want to thank you very much for your attention. And if you have any questions, maybe we can get back with you by email. Thank you.